Hi everyone, it's Dr. Lindner. Let's take a look at the EKG. Some basic understanding, right? You're not going to learn what cardiologists do, but some basic understanding to know what perhaps paramedics can pick up. So, in order to understand an electro EKG, an electrocardiograph, K for cardia in German, because if you say ECG, sometimes ECG sounds like EEG. If you're in an emergency room setting and you go, I need an EEG stat, you're like, did you go EEG or ECG? Electrocardiogram or electroencephalogram, these are different. This is the brain, these two are the heart. So the pacemaker of the heart is the SA node. When someone gets a pacemaker, they're replacing this, the sinoatrial node, the SA node. It sends the electrical current to both right atrium and right ventricle. It's going to relay that to the AV node. AV is the atrioventricular node because it's right between the atrium and the ventricle. The AV node is going to relay the electrical current to the bundle of His. The bundle of His then divides into a left and right bundle branch. Have you ever heard maybe a paramedic does an EKG and they go, oh, he or she has a left bundle branch block or a right bundle branch block? If you have a left bundle branch block, that means that the electrical current is never going to be able to make it to the Purkinje fibers to make the ventricles contract down here at the bottom. So there's a left and a right bundle branch. These are the bundle branches. And then the bundle branches divide, the bundle branch divides into these Purkinje fibers. Now, an EKG is measuring the electrical conduction system through the heart. And we're going to be looking at something called the PQRS T wave. Usually the P is by itself, the QRS is by itself, and the T is by itself. So we're going to look at the P, the Q, oh, that was horrible, the Q, I put that in a triangle because it's kind of like that, the QRS wave, and then here's the T wave. Let me erase that because that was just super sloppy. Okay, so we have the P wave, the QRS wave, and then the T wave. Now, next to each of these, we see that the P wave is happening during atrial depolarization. The QRS wave is happening during ventricular depolarization. The T wave is happening during ventricular repolarization. So the key is, all right, what do we mean by depolarization? And what do we mean by repolarization? So when I hear depolarization, I think contraction. When I hear repolarization, I'm thinking of relaxation. When there's contraction, I also think of systole. And when I think of relaxation, I think of, oh, let me erase that. When I think of relaxation, I'm thinking of diastole. Systole over diastole, contraction over relaxation, right? When we take blood pressure, 120 over 80, the amount of pressure in our ventricles or in our blood vessels at the time of contraction is 120 millimeters of mercury over 80 millimeters of mercury. 120 over 80. Blood pressure should be less than that. So again, depolarization, we're thinking contraction. Repolarization, we're thinking relaxation. So if we look at this little wave right here, look at the contraction size when the atrial depolarizes. So that means when this atrium contracts, we see this little bump. Why do we see just a little bump? Well, in comparison, the atrium is on top. So remember, gravity itself can dump a lot of blood from the atrium into the ventricle. Then we need a little bit of a conduction, a little bit of a contraction to push the rest of it out. So we see a little bump. But think of what's happening here in the left ventricle. When that left ventricle contracts, it has to pump blood up to the arch of the aorta to pump blood to the upper extremities, all the way down to the abdominal region and the lower extremities. So when the ventricle contracts, think of how thick that myocardium is, how thick the musculature is. So look at the electrical wave when the ventricle depolarizes, which is contraction, much, much stronger. So the QRS wave is pretty strong. And then when the ventricles relax, we get this little bump again. Okay, so a cardiologist is looking at the PQRST waves, not just one of them. They're looking at many cycles of this. They're looking for patterns. Nothing is diagnosed based on just one abnormal pattern. They need to find many. They need to find a sequence of these patterns. Maybe they find an abnormal to the PQ interval, meaning the space between the P wave and the Q wave is called a PQ interval. Maybe there's an abnormality to this QRS complex. Or maybe there's abnormality between the S and the T called the ST segment. So when there's heart damage, like a MI, a heart attack, or a myocardial infarct, we can see here's a P, Q, R, S, T wave, and that one's normal. But look what's happening here. Here's a P, Q, R, S looks good, but what's happening to the T? Well, that's an inverted T wave. Now over here, we have a P, Q, R, S, T. So this ST segment is elevated. There's an injury here, whereas here there's lack of blood flow. So you get a lack of blood flow with that inverted T wave. When you have lack of blood flow, there's lack of oxygen. Lack of oxygen results in an injury. And then what happens? Look, you get a P, look at that Q, R, S, T wave. Look at this Q wave. It's a significant Q wave. That's an infarct. So we have a myocardial infarct. An infarct is when there's no blood flow for a while and it gets injured. When there's no oxygen, it becomes necrosis. It turns black and dies. This is what a heart attack or an MI or a myocardial infarct looks like. That's the myocardium. It is damaged. This cannot be regenerated. It's dead heart. Okay.